Sutton. This is Road to Recovery. My guest today, Angela Caldwell from Montgomery Recovery Services. Welcome, Angela.
Hi, thank you. I'm happy to be here.
Can you tell us a little bit about yourself?
Sure. So I've been in the addiction field for over 23 years, but I started out in an inpatient setting. So everything that I knew about recovery was very abstinence-based.
Okay.
I grew up in a home where I always joke that I knew the Serenity Prayer by the time I was 5. I had active members in 12-step recovery. So my experience was very abstinence-based, AA meetings.
Okay.
And I kind of accidentally tripped into medicated assisted treatment. Now, this was back in the days where when you used to look for a job, it would be in the newspaper post.
Wow.
And it said Outpatient Treatment Center in Rockville. And I thought, oh, okay, this would be great. I was at Avery Road Treatment Center. I had actually started out as Avery Road's first intern, and then I was a counselor there and an evening supervisor. So I wanted to kind of transition to outpatient treatment.
Okay.
So when I interviewed, they said, so what are your thoughts about methadone? Because this is back when it was referred to as methadone clinics. That was the only medication we were using at the time. This was 1998.
Okay.
So everything I had heard was very negative. I heard it was kind of like a legal dope strip and everybody's selling drugs in the parking lot. And I'd heard all these terrible, anecdotal stories about it. But I gave the most honest answer that I could. And I said, honestly, I don't know enough about methadone to have an opinion.
Okay.
And my bosses liked that, and I liked it, and they hired me. And I always say that I'm so grateful for that opportunity, because it was such a learning and educational experience for me. My program director at the time used to take me to these meetings in Baltimore where we'd go to these other clinics where we'd have these, it's called MATOD, it's like Medicated Assisted Treatment of Opioid Dependence, and we'd have these little meetings in this Man Alive, which is the oldest methadone clinic, I think, in the country.
Cherry Hill?
It's in Baltimore.
Oh.
Yeah, I forgot what street it's on. But, he used to take me to these meetings, and I learned so much about, at the time, again, it was only methadone, but about opioid replacement therapy. And I was so thankful because it was just a whole new world for me.
Okay. So now that you have been there for a while, can you tell us, because I looked at some data and it said methadone, it really has the data shows that it's really the most effective treatment actually for opioid dependence.
Right.
But a lot of people are still, like you said, because of the stigma, the recovery community, the public, even professionals still have stigma about methadone, Suboxone, and Vivitrol. Now, which medications do you guys use at Montgomery Recovery?
So at Montgomery Recovery, right now we use methadone and buprenorphine.
Okay.
And I'm glad you mentioned, how actually the World Health Organization, they stated that methadone and buprenorphine are essential medicines.
Wow.
So, we always say it's not effective. They've used the term essential, and it's just the best tool that we have for what we call this opioid crisis. But in our center, we use methadone and buprenorphine.
Okay. Now, we hear a lot about the opiate epidemic, and I know where I work at the jail at Montgomery Correctional Facility, we're starting to carry people who get arrested that are on a methadone maintenance or buprenorphine or Vivitrol. We have a mandate from the state that we have to continue their treatment once they're arrested. So this is a new thing. It's just started in January.
Right, in January, yeah.
Right. So we're like tearing our hair out trying to figure out how to make it work, right? But I'm sure that it will help. A lot of people leave the jail and not OD.
Exactly, because that's one of the most critical times for patients with opioid use disorder is, like, for example, if someone is just released from being incarcerated, they are a priority. We take them right away because the overdose risk is so high.
Oh, wow, okay. And also, you're on the task force. Can you tell us about that?
Oh, yeah, the overdose fatality review team.
Yeah.
So we basically review all the overdose deaths in Montgomery County of illicit substances. And one thing that I noticed is we've had former patients from Montgomery Recovery Services. Unfortunately, they've been on these review teams. And one trend that I noticed, they were not enrolled in treatment. You know, they don't perish when they're in medicated assisted treatment. So it really kind of validated for me just how important medicated assisted treatment is.
Wow.
Because unfortunately, a lot of them, if they're not, established in recovery,
right.
This disease is deadly.
Right. So methadone can be definitely one of the tools to reduce the overdose deaths.
Absolutely.
And we really have to reduce the stigma. Now, tell us about, with the clients that you have, how long do they usually stay in with you guys? Is there a window of,
right. It varies. We have some clients that refer to themselves as, they say, lifers. And that just means these are clients who have opted to stay on the medication for life. They tell us, they're like, it's the most effective medication that I've ever been on to combat my addiction. Sometimes it helps with pain analgesia. I've had other clients tell me that it's even helped them with depression, anxiety. They're like, this is such an effective medication for me that they've opted to stay on it for life. I will tell you that the majority of patients that come into a medicated assisted treatment program, their goal is to detox.
Oh, okay.
There's this misnomer that, they're just getting on there so they could use and, not be sick. And it's like, most of our patients do not want to be dependent on a medicine.
Oh, okay.
And one thing that I do a lot of, I think I was telling you before, I do some recovery coach training with recovery coaches in DC. Mm-hmm. And one thing I say to the participants, because, even recovery, like you mentioned before, a lot of people in recovery even have stigma. They have very strong feelings about medicated assisted treatment. And I always say to the participants, in what other arena do we question how long someone is going to be on a medication with a chronic disease? What if I said to you, James, when are you going to get off that insulin? Or when are you going to get off that heart medication?
Right.
Or when are you going to get off that Lexapro?
Right.
We don't do that with other chronic illnesses, but I think we all feel like we're armchair experts when it comes to opioid use disorder and how long they should be on a medication. At our program, one thing that we do is every 90 days we assess with them. We do a 90-day summary, and we say, so, where are you in your recovery? Have you thought about taper? And usually the response is, I do think about it, but I'm scared. And then that's when we do motivational interviewing, and we determine, are they at a place where, they're ready to taper? Right. If they're going through a divorce, if they're going through an eviction, they got 3 court cases, it's not going to be treatment recommended to detox. But if someone's been stable for a couple of years, they've got 12-step recovery, they're working, they're stable, then we say, let's talk about a taper. So we just try to meet them where they are. But they're in various levels of how long they stay. And that's actually what's kind of unique about harm reduction. It's very different than like a 30-day or 60-day where there's an end date. This is very individualized.
Right. I'm glad you mentioned about the way we separate opiate dependence from other chronic diseases, because that's another thing. We don't actually say a person on methadone is in recovery until they stop using methadone.
Exactly.
But actually they're in recovery.
They are in recovery
already. But the recovery community feels that you're not in recovery unless you're abstinent. But actually they're in recovery. So I'm glad you mentioned that. No other chronic disease we say, you're in recovery when you're being treated and when you're lessening the harm and your quality of life is improving. So I've seen some footage of women in England on methadone, and they're dropping their kids off at school, they're working and things like that. So how's the quality of life of your clients? Are they working? Are they able to go to school? Do you see that kind of?
You do, and again, the population varies. I mean, we have, from the indigent, there's some that are homeless, and their lifestyle right now is very chaotic, and there's a lot of instability. And, most people that come to treatment, they're kind of in a crisis. We have people that have professional jobs. I've had nurses, I've had EMTs. As we live in Montgomery County, so it's a very affluent suburb. So you're going to see a lot of professionals. You're going to see teachers. So, but it varies.
Okay.
But I've had clients say that it gave me my life back.
Wow.
Because, you know, they could function. They could not have to think about, you know, when they're going to get their next fix, and they're established. They have a counselor. They have people they can talk to. There's accountability. So, and, you know, there's various stages of recovery. There's people that come in and they think this is the best medication and they stop right away. There's people that come on and they still like use and they have to get to a stable dose. You know, it's just varying levels of stability. And, you know, I always tell people who still have an issue with it, you can look at it, its very basic need is that it's harm reduction until the patient is ready. So again, you have to do a lot of meeting them where they are. Right.
Now, do you have like Methadone Anonymous class meetings at your site, or are there any in Montgomery County?
That's so funny you say that. We used to have an MA meeting established at our program about 15 years ago. And I recently had clients who said they were very interested in an MA meeting. I haven't seen a lot of MA that I used to see about 15 years ago, so we're actually doing research because the clients actually want to start an MA meeting at our facility.
Oh, good.
Because unfortunately, they feel very stigmatized by the traditional, you know, NA and AA. You know, they tell us that they're told that they're not clean, so they don't feel like they always have a home there. I do have some clients that attend meetings, and they've just opted not to tell them. Mm-hmm. You know, they're like, I follow the steps. I have a sponsor. They feel like they're being, you know, dishonest, but they're just not going to take me serious if I tell them that I'm on, you know, methadone or Suboxone.
Right. Yeah, that's a real challenge for the recovering community. And, you know, recovery coaching, like the CCAR, you know, when we start embracing recovery coaching and the concept that you're in recovery when you say you are, then, you know, we can more embrace people who have different pathways, whether it's church or methadone or Islam or whatever, right?
I mean, we laugh. You know, AA and NA were the only game in town for a long time. Now we got Smart Recovery. Yeah. And when I do that recovery coach training, I tell them, you know, there's a new advocacy group. There's a shift from Medicated Assisted Treatment to Medicated Assisted Recovery. It's called the MARS Project. So it's coming around the bend.
Yes. And so we're going to take a little break in about a minute or so, but I'm glad you said that too, because I changed the name of my workshop at the jail. You know, I do a medication-assisted therapy group, and it really used to be called the Vivitrol group because we got money to start giving Vivitrol in the jail about 3 or 4 years ago, right? So I was kind of like educating people what Vivitrol is because nobody really knew what it was, right, and how it could help you when you left the jail not overdose, right? So now we recently changed it to Medication Assisted Recovery Group.
Wonderful.
So we want to change the language that we use so we can start looking at not stigma, you know, and not being cutting people out of recovery and be more inclusive.
More inclusive, exactly.
Yeah. So I'm a person in long-term recovery, but in an NA meeting, I have to say, I'm an addict, right? So language can help a person or hinder a person, you know? So we're going to take a break right now, and then when we come back, we have some more great questions for you. All right? This is James Sutton. We're going to take a break right now. We'll be right back with Road to Recovery.
They gave me Vicodin after my knee surgery. They kept prescribing it, so I kept taking it. I didn't know it would be this addictive. I didn't know how far I'd go to get more.
Opioid dependence can happen after just 5 days. Know the truth, spread the truth.
Hi, it's James Sutton. It's Road to Recovery, and we're back with Angela Caldwell. So Angela, we were just talking a little bit about treatment on demand, and you were talking about some of the services you've been providing for different other agencies in Montgomery County in your life at Montgomery Recovery Services. So I know we've really been trying to get treatment on demand so that when a person's ready to go into inpatient or treatment, there's a bed available. How does that work with methadone? The person says, I need methadone, how long, do they have to wait 2 days or a week, or
Right.
how does that work?
Because, we're level 1, we only have so many hours allocated. We don't have a doctor 24 hours a day.
Okay.
But what we've tried to do is really implement telehealth. So at our program, we have medical staff for admissions every Wednesday and every other Friday. So I've talked to hospitals in the area, because one challenge that they have is the ER is inundated with people that have opioid use disorder. And let's say they come in on a Friday and then they want to release them on a Sunday, and most medicated assisted treatment programs are closed. So we've really tried to encourage them to give them Suboxone scripts for a couple of days, or legally physicians can prescribe methadone for 3 separate days, like 3 separate prescriptions, until they can get into a program. So we've really tried to make ourselves available to have that kind of stopgap, where if we had to, we would do the telemedicine, and then our physician would do a full examination once they're on site. But there are things we can do to bridge that gap, because that's where you lose the patients.
Right.
And we've also, wanted to talk to jails too. We're very comfortable delivering doses. We're very comfortable with chain of command. We've been delivering doses to nursing facilities for over 20 years.
Oh, wow.
So it's something that, we always believed in the continuity of care.
Right.
And and as you know, it was a challenge, especially with, our medicated assisted treatment programs. They weren't even historically allowed in a lot of inpatient facilities, some halfway houses.
Yeah.
Thankfully, that's changing.
Right. And I'm glad you mentioned that too, because there still isn't a lot of sober houses that will let a person that's on medication-assisted therapy live in a sober house. It's still that stigma, even in the recovery housing community, and that's really crazy, because like you said, our population is varied. Some people are professional and have homes, but some people are homeless. Some people are transitioning from homeless.
Right.
And their next step will be transitional housing or sober housing, because it's inexpensive and it's a peer, driven environment where they can actually, learn some life skills and things like that, not just stay off drugs, but actually learn some life skills too. And it's not really conducive, to the health of the community, to turn our back on people on medication-assisted therapy that need housing. So I'm glad that you guys are doing that in the ER, because a person can leave the ER and go at OD.
Right.
So that's a
Especially
great
with the
service.
fentanyl in the street, it's a crisis. It's an epidemic for a reason. So we really want to try to keep that continuity of care, and it really works well when all the systems speak. Like the jail speaks to the treatment centers. We speak to the hospitals, and I always try to really help those in the community, because I realize for a lot of physicians, they don't even really teach addiction in medical school. So I've actually had to consult with physicians, which is,
You had to teach them.
I've had to teach them, and thankfully they're thankful for it. But, this is new for them, this whole, opioid use disorder. They're like, well, do I give them pain medicines or do I withhold it? So
Who's the doctor?
Yeah, who's the doctor? Or,
Right.
It's like, hey, maybe you don't want to give them 100 benzos, when
that
they're
might not work out.
100 milligrams of methadone. So, but it's important that all systems of care, if we coordinate and we educate, it's better for the patient that everyone's involved. Like when our patients come to our program, we're like, you have to sign a release for your psychiatrist, you sign a release for your probation officer, anyone who's involved in your care. And we always tell them it's for your safety.
Okay, and that's a good point too. In your facility, what does your treatment team consist of? Who's on your treatment team? Is there a psychiatrist, a recovery coach, a therapist, a counselor?
Well, we're a small facility, so our treatment team consists of our medical director, our nurse practitioner, our dispensing nurse, myself, the program director, and the therapist.
Okay.
Because we're level 1, a lot of our services is referral based. So I try to do a lot of work in the community, like whenever there's new behavioral health centers, I always reach out to them and let them know we're in the community and see what kind of services they have, because we're going to refer our patients. And it's important for us to find services because we have a big Medicaid payer mix. So a lot of our patients are on, have Medicaid insurance. So it's also very important for us to know, like, for example, Capital Dentistry, Montgomery Village takes Medicaid, and they do payment plans with our patients, which is nice because a lot of them have dental issues.
Right.
So it's really important for us to know what are some, valid services in the community, because we're mostly referral based.
Which reminds me of, is this a myth? Because I always heard that methadone eats up your bones and your teeth. Is that a myth, or is it because those people were getting poor health care most of their life when they were shooting dope, and then now that they're on meth, their body was already worn down from lack of health care for 20 years on heroin? So how does that work?
I always say it's threefold, because believe it or not, a lot of dental issues are genetic, believe it or not. Like, you'd be surprised how much are genetics. A lot of it is lifestyle choices, neglect. Methadone does have side effects. It does decrease the saliva production. So if you're looking at someone who already has compromised dental hygiene, then it's going to be, it's going to worsen. So it's threefold. It's all the above.
Oh, okay. Right. And I know that we've been talking about bringing recovery coaches from Tree of Hope to work with you guys. So we're looking forward to that. That'll be our first, partnership with any program that had medication-assisted therapy. And we're excited about bringing recovery coaches to your program.
It's so needed. I mean, our clients, they need to feel like they have advocates and people in their corner, because like I said, a lot of our patients, they know the stigma.
Yeah.
And they feel bad. They feel like, why couldn't I do it like my friend who went to NA and is celebrating 10 years? Why did I have to go this route? So not only are they facing stigma, they're also facing their own self-judgment. And they would really benefit from recovery coaches who would help them through their process and who also are supportive.
Right. Yeah, this is definitely going to be a great partnership. We're really looking forward to that.
I am too.
And I appreciate that you reached out to us to do the Narcan training. I know that I came over and trained clients and staff, so that was great that you were educating your clients and your staff on overdose response. Hope more and more of your clients, because even if they're in a program, they may come in contact with friends who are still actively using it, may come in contact with that fentanyl, because we're losing, I think, over 200 people a day nationally.
Yes.
And Montgomery County is not exempt.
For sure. Unfortunately.
So now, are there any, is there anything that we didn't touch on that you feel is important that you want to share, gaps in services or things we can do better?
I think we talked about before professional buy-in as well.
Professional buy-in, yeah.
Because,
definitely.
you'd be surprised how many professionals that you talk to in the field who still have very strong oppositions to medicated assisted treatment. And I think we all need to be patient with each other. Like, one thing that I think about is we've really only accepted addiction as a chronic medical brain disease. I think it was the 50s.
Yeah.
So we're still in the infancy.
Yeah,
like we
right.
still, there's a lot that we're learning, and I'm so thankful. I remember when it was methadone only, and now we have Suboxone, now we have Vivitrol, now we have Sublocade. Mm-hmm. Now we see commercials that talk about opioid use disorder.
It's true.
We've even changed the lingo. You were talking about earlier how these labels, instead of now saying addict, now we say opioid use disorder. So we are still in the infancy of figuring out, there's still no cure. But I think as professionals, if we all get together more and consult and talk about these things and bring everything to the table, we used to only teach 12-step was the only way. Don't get a sponsor. We have to broaden our horizons. So
yes.
I think the more that we have these dialogues and conversations, I think we'll get more advanced with, just the field of addiction in general.
Right, and I agree. And one way I think we can achieve that goal is that we're going to have you do in-services in a lot of different agencies.
I'd be happy to.
Because, like you said, the professionals, you know, first of all, a lot of the professionals, they really weren't trained in addiction in the first place. You know, they were trained as social workers.
Right.
So addiction is not really the crux of their, you know,
Right,
education.
the training.
Addiction is only a small part of it. And then when you add medication assistance therapy, that's even a smaller
whole
part of the
different
addiction
animal.
part. So
Right.
the go-to has always been, you know, send them to the 12-step. That'll fix them.
Right.
You know, so we really need you to come and educate the professionals about what exactly is happening in your area, and that's you know, like I said, the meat of your program is medication-assisted therapy. So you're an expert on that. As a matter of fact, I was talking to Monia about she wants to bring you in to talk to our whole forensic team.
Okay.
So we're
I'd be happy
gonna
to.
plan on having you come and you know, let us know exactly, you know, what's going on in your area with medication-assisted therapy. Do the clients respond? Do they relapse? You know, is there any kind of special treatment plan or exit plan or recovery plan? Or,
Right.
you know, we're ignorant to how to deal with that particular, you know, population. But you have, you know, you're an expert, so we have to tap into you as the
Yeah.
resource, right? So we're going to look forward to that. And I don't have the date yet, but I'm going to get with you.
Okay, yeah, I'm excited
Whenever
about
they
that.
give me the date, we wanted you to come and present for the forensic team.
Okay.
So we'll know. Because now, I tell you, we have to, well, our first approach is going to be to provide medication-assisted recovery for everyone that's incarcerated, that gets locked up, that's you know, already in a program. But then the next stage is anybody that is an opiate dependent person, even if they're not in a program. We don't want them to leave the jail and OD. So we're going to.
great.
So that's going to be a huge population of people that, you know, have never been in treatment, but is an opiate user. We want to treat them too. So we're definitely going to have a lot of staff that needs to be educated. You're going to be our go-to person.
Oh, okay. Yeah, I'm actually developing a trait. You know, I think they call it opiophobia.
Okay.
Like when, you know, if it, like, again, like if a physician gets someone, and let's say they know they're on a program, but they're like, I'm not sure. Do I still give them medication? Should I give them ibuprofen? Should I give them naproxen? Is a little bit of, you know, hydrocodone, you know, clinically indicated after a dental procedure, you know, and it's understandable. I mean, we went from, you know, giving it out like candy to giving them nothing, and it's like, okay, we got to kind of meet in the middle, and kind of, and that's why we have to have these like conversations and consult with people who've worked with this population for a long time. So I'm really excited that, you know, Montgomery County is, especially with the jails, like we're, you know, because our patients are terrified of detox. They are terrified. So I'm glad we've come a long way.
And I'm glad you were with us today. We're about at the end of the show. Thank you so much for being with us. We'll have to have you back. And next time when you come back, we'll have you bring, you said you had a client that wanted to come and talk about his experience or her experience being on medication-assisted therapy. So this has been Road to Recovery. My guest today was Angela Caldwell, and we'll see you on the Road to Recovery.